The lecture for today, students, it's about the occlusion and positioning the denture teeth. Occlusion. The occlusal schemes provided for complete dentures differ significantly from those found in most natural dentitions. The dentate occlusion is often canine guided or demonstrates groove function. Uh, of course, in each case, the teeth contact on the working side, but usually disclude on the non-working side a lateral exertion, as we can notice in the image on the left side, at the upper and the lower one, at the top and the bottom. Similarly, the posterior teeth disclosed in protrusive excursion, which is called Christensen's phenomenon. Dentures are different. The occlusion is designed to provide stability. Therefore, the non-working side teeth also contact in lateral excursion to prevent the denture from tipping, giving rise to the term balancing side, okay? As we notice with the images A, B at the middle. The posterior teeth also contact in protrusive excursion. Uh, uh, as we notice, for example, in term of the left images, A, with the for natural and B for the lingualized occlusion. We have a setting of teeth in natural occlusion and in lingualized occlusion, and we discussed this previously. Okay, it can be a challenge to achieve such an occlusal scheme. The contacts must be harmonized in intercuspal position, lateral excursion, and in the protrusive movement as well. To add to this challenge, the occlusal scheme, which must first be established on a device that mimic the patient's mandibular movements before being confirmed intraorally. It follows that the articulator on which the occlusal scheme is established should reproduce the movements of the mandible precisely and allow for movement that may occur during mastication. This to simulate the movement of the mandible. Okay? Now, the balanced occlusion refers to the occlusal scheme that is provided for dentures and features. And of course, we have the intercuspal position, ICP, which equal retruded contact position, RCP, and this will be intercuspal position on posterior teeth. The working side and balancing side contacts in lateral excursion, and the anterior and posterior contacts in protrusive excursion. Now, the intercuspal position, equal retruded contact position. The intercuspal position contacts are established on the artificial teeth to coincide with the retruded contact position recorded at the registration stage. Having the intercuspal position and retruded contact position coincide allows the wearer to function from centric relation, which is considered the optimal position for function and comfort in case of artificial restoration. The intercuspal position on posterior teeth, the intercuspal position on posterior teeth, these contacts are established between the palatal cusp of the upper teeth and the contact fossa of the lower teeth, or the contact fossae of the lower teeth, because you have two fossae when the upper teeth occluded with. The buccal cusp of the lower also contact the central fossae of the upper teeth, and the intercuspal position contacts may occur on anterior teeth where the skeletal classification permits. That means in case of class 3, as we can notice at the image on the right hand, okay, which may be complicated by a crossbite. Now, in terms of working side and balancing side in lateral excursion, during excursion, the excursion, as we previously mentioned, that the movement of the mandible in a way different than the occluded. That means whether it is laterally left or right, or protruded or retruded. Now, the upper palatal cusp, focus on the images on this slide, and as we discuss the position of each cusp. The upper palatal cusp of the working side teeth maintain contact with the buccal facing slope of the lower lingual cusp, as shown here in the upper image. Okay. Now, the lower buccal cusp maintain contact with the palatal facing slope of the upper buccal cusp, as shown at the image on the left, the lower left one. While on the balancing side, the upper palatal cusp maintains contact with the lingual facing slope of the buccal cusp, as in the image on the right side. And the greater the number of ballast contacts during this excursion, the greater stability of the denture, of course, because we don't have a natural teeth within the socket of the bone, so we want to stabilize our denture. So on this term, the denture will be more stable. Okay? Now, with the anterior and posterior contacts and protrusive excursion, as at the image on the left side, during the protrusive excursion for the patient within the complete denture, the anterior teeth contact and simultaneously contact should be provided between the posterior teeth to prevent the denture of dislodging. Otherwise, the space between the teeth lead to fall the denture, the upper, the maxillary denture to fall down, and the lower move upward, forward. Now, all of contacts in excursion are produced to harmonize with the mandibular movement, which itself is determined by the movement of the condylar head as it travels down to the articular eminence. What the difference from the lingualized occlusion at the image on the right side, we notice that there is different points remarked by a red pencil. Okay, now we will discuss what the lingualized occlusion is. A modification of the balanced occlusion is the lingualized occlusion. What's that mean? This differs in that the artificial teeth are designed to have fewer intercuspal position contacts. Okay? While still distributing the occlusal load centrally over the alveolar ridge. Now, compare the lingualized occlusion teeth patient with the natural occlusion teeth on the other side. We notice that that's mean comparing the lingualized occlusion teeth with the patient with the left side. These are the marked line which is uniformed one on the left side, while at the right side we can notice that the lingualized occlusion become occluded in different contacts, with different contacts, this to provide stabilization. So with the lingualized occlusion at the images on the right side, the right part represent the lingualized occlusion, the left part represent the natural occlusion, and of course the occluding with the lower is vice versa, as we notice with the A and B. Similarly, when moved into lateral excursion, there is only one contact between the palatal cusp of the upper teeth and the buccal and lingual cusps of the lower teeth. To ensure the single contacts produce a stable denture, the occlusal contacts are positioned directly over the mandibular or alveolar ridge. Okay? This resulting in a narrower distribution of contacts and pressure directed centrally over the ridge compared to that seen when using natural occlusion teeth. Of course, the distribution of the force with the occlusal table in terms of natural occlusion teeth is different than the lingualized. The lingualized become narrower, the occlusal table become narrower, so the load limited to a limited area. This occlusal arrangement is also produced to confirm the mandibular movements of the mandible, and thus also requires appropriate selection of articulator, which is essential to find out the proper way of setting of artificial teeth. Until now, we recognized all the important points regarding the working and the balancing side, and what the difference between the setting of teeth in natural occlusion and setting of teeth in lingualized occlusion, and of course setting the position and the context of natural teeth with the patient, natural teeth, and the contacts within the natural occlusion in terms of artificial teeth and lingualized occlusion as well. So now with the positioning of the denture teeth, what's important about the positioning of the denture teeth? It's not only arranging of the teeth in terms of getting mastication and so on. It's also regarding creating a denture that is aesthetic, retentive, and stable during function. And this is the challenge. So to have all these factors within one restoration, this needs to point out the most important factors and the way and the steps which aid us to setting the teeth in proper position to get all these factors together and to achieve a proper functional restoration by the complete denture restoration. However, there are anatomical landmarks that can help in establishing the optimal position of the teeth. The denture teeth should be positioned to create, of course, aesthetic appearance by sitting the anterior teeth in a natural position relative to the alveolar, incisal papillae, and lip. So, the setting of teeth is aesthetic appearance coming from what? The sitting the anterior teeth in natural position relative to what? First, alveolar, bone. Second, incisal papillae. Third, the lips, the high line. So, within the alveolar, to distribute the force alongside the alveolar bone. Incisal papillae, there is a wrong identification for the midline, which is referred to the frenum. Mostly, this is the wrong way to identify the midline, the aesthetic midline between the two upper centrals. Now, the most important thing to focus on the marking line which bisecting the incisal papilla, and this transferred to the occlusal bitrim, and then to identify the bisecting line for the right and the left side for aesthetic purposes. And of course the lips. Otherwise we have many patients with the high lip line or short lip line. So we are looking for a proper aesthetic issue, looking for to position the anterior teeth. Now also the second thing, which it is the denture teeth should be positioned to create a stable denture by positioning the teeth over the central position of the alveolar ridge, as we can notice on the left, the image on the the image on the right side. So the positioning, the stability of the coming to the stability during chewing by centering the primary chewing teeth over the most favorable part of the ridge. It is an analogy seen with the position of the saddle on the horseback, as shown in this image. This lowest area is the same within the lower arch. This is the most stable area for the denture, and mostly the last functional tooth placed over this area. Okay. Now, stability, marking the stable position on the patient alveolar ridge using pencil, and there is many tools to be used for in this term with the probe. This will ensure that the large molar tooth is sited over this spot. Okay, this ensuring the stable denture. Okay, with this technique. Now, stability of the lower denture by creating harmonized non-antagonistic contacts between the mandible and the maxillary teeth during lateral and protrusive excursion as well. Now, rotation also ensuring that the denture teeth are held within the natural neutral zone, or which is called the potential denture space. The location of the denture, whether it is over the alveolar bone, the buccolingually, mesiodistally location, should be in neutral zone. And this zone, when an area that exists between the forces exerted by maxilla, the muscles of the cheeks, lips, and tongue, like the auricularis aureus for the lips, buccinator muscle for the cheeks, and of course the muscles of the tongue. Now, the shape, the size, and position of the anterior teeth provided the primary aesthetic of the denture. There are two occlusal schemes that may be used when designing the posterior teeth contacts balance: the natural or lingualized. Now, each scheme uses the anatomical landmarks described above, as we mentioned. That means and below to determine the position of the teeth. What we are going to discuss now regarding this issue, as we said, it is important positioning the teeth in the neutral zone for stable denture. Now, coming with the anatomical landmarks that aid in positioning the denture teeth, we are generally have too many landmarks within the maxillary and mandibular edentulous arch. However, there are many landmarks within the maxillary edentulous arch and the mandibular edentulous arch, were really important for us to know about them in terms of their effect in our restoration later on when we designing the restoration. Now, starting from the upper border, generally I'm gonna mention many important maxillary borders and mandibular borders, and then we are going to find out these landmarks and what the demarcation will be in the denture later on. So, starting with the maxillary borders, the midline, midline reference plane to achieve anterior symmetry, and this is important. The rugy area may be used to locate canine, for example. Tuberosity, maxillary tuberosity defines maximum posterior border of the occlusal table. Labial sulcus used to assess the vertical dimension. The hamular notch distal to the tuberosity defines the maximum posterior border of the denture. Vibrating line, position of the bozdom, of course the maximum distal border of the denture for V. palatini, and the alveolar ridge. This is for the upper. Okay, starting with the upper borders, starting with the labial frenum. The labial frenum, it's one-fold, noticed within the anterior border between the lip and the alveolar ridge, and this will be, of course, the labial notch in the denture. So this frenum, it is important to be identified properly within the impression, so the dental technician can create the denture within the limits, and the labial frenum just finished and polished in proper way and according to the frenum attachment, whether the movement to the right, to the left, or at the mid. Buccal frenum, and this could be single or doubled, and this will be a buccal notch in the denture. Of course, as well, the direction of these frenums, it could be directed forward or backward, and sometimes backward, forward, and this should be well presented by the denture later on by finishing and polishing this part properly. Now, the labial vestibule, which is located between the lips and the alveolar bone, and this will create the labial flange of the denture. The borders should be about 2 millimeter in thickness and should be round and smooth. Otherwise, this may be act as a knife on the labial vestibule for the patient. The buccal vestibule extended from the buccal frenum to the end of the ridge, the demarcation until the end when started the posterior palatal cell area, and this will be a buccal flange in the denture. Okay, and of course, as well, we should finish and polish it properly with a round surface to avoid cutting the smooth surface of the patient sulcus. Within the upper borders, also the residual alveolar ridge, which is considered as primary stress-bearing area, of course, and this will be a ridge fossa in the denture, and should be identified properly within the impression to be created later with the fine details within the denture. The upper border as well, the incisor papilla. The incisor papilla, as we mentioned previously, it is important to identify the bisecting line between the right and the left, and this will be incisor fossa in the denture. And of course, this must be relieved to avoid included the pressure of the denture on it. Otherwise, the nerve supply coming from it will lead to numbness of the anterior brygma, the anterior area. Many patients suffering from losing the sensation within the anterior part of their lips after a while of wearing denture, and that's because most of the mistakes in preparing complete denture not to relieve this area, which leads to make the pressure of incising over this area and lead to cutting or the nerve supply to the anterior part of the mouth, leading to the numbness and sometimes losing the sense completely. The zygomatic process, molar process, this will be a ridge fossa in the denture, and it's located at this area properly within the first molar area. This is probably due to the large 3 molars of the first molar region, which is mostly the thickest area within the alveolar ridge. Also, we have the maxillary tuberosity here, which is represented by the ridge fossa in the denture, which is located posteriorly. As well, the pterygomaxillary notch, the hamular notch, and this will be the pterygomaxillary seal in the denture. at this position, which is almost the last part when the seal of the posterior palatal seal will be start from. Okay. The median palatal raphe, which is located at the mid of the upper maxillary, the maxillary edentulous arch, and this part is created due to the union of two halves of the right and the left, and this is not really hard palate at this area, and it is sensitive, so mostly this will create a palatine groove in the denture, and sometimes with the deep palates, and we have to relieve this area to avoid the pressure at this area. Now, vibrating line of the palate, which is called the L line or area. This is the posterior palatal seal area in the denture. Of course, this is the line or area. It depends on the type of the palate of the patient. Sometimes this is like a line, or it's an area to be created like a butterfly area. And the vibrating line position of the bosom, the maximum distal border of the denture is there, the fovi palatini. At this line, within the vibrating line, this is the last border of the denture will be the last part of it will be the start of this vibrating line, and it depends, as I mentioned previously, it's either line or area. It depends on the connective tissue between the hard and the soft palate. Okay, now the fovi palatini, there are two dots behind the vibrating line, which is 1 to 2 millimeter, and of course these are to supply the soft palate and the last part of the palate within the nerve. These are not included within our denture, but should be avoided. Otherwise, the patient may have a gag reflex, or sometimes the sense of breathing will be affected, and the soft palate not worked well, leading to suffocation or sometimes problem in swallowing, because this lead to parallelism of this of the soft palate. And the location, as I mentioned previously, 1 to 2 millimeter behind the vibrating line or area. Okay, now the rugi area, these are a bony structure configuration of the anterior part just behind the two central area. This will be the rugi area is important to give a secondary stress bearing area for the maxillary arch. Okay, to be well tolerated for the falls, and of course this will be as a rugi depression in the denture. The canine eminence, this located just at the position when the canine was there. Mostly the patient with complete denture, the last tooth to be lost, the canine, because of the large and because of the longest root, and that's why mostly we have this canine eminence, and it's a good demarcation for us to locate the canine in terms of misunderstanding the positioning of the setting of teeth. And the canine eminence will be canine fossa in the denture. Torus palatinus. Torus palatinus is a bony configuration at the mid of the palate. Sometimes it's a large, so it's need to be in terms of constructing complete denture, we need to surgical removal. Sometimes mild or shallow, so we need also to relieve it and do not include it in our design. Otherwise, this will exert force on it, and this is a bony structure, may lead to resorption of the bone. And this area, as I mentioned previously, it's located also within the raphe area, the median suture. This may be lead to perforated, exposing to the upright maxillary sinus sometimes. Now we are already knowing the landmarks that help us to to in the maxillary arch that aids in positioning the teeth. Now, the mandibular anatomical landmarks, we have many landmarks in terms of, for example, a retromolar bud, labial sulcus, alveolar ridge, buccal shelf, external oblique, or mylohyoid ridges, where these are probably the most important thing to put in our mind and how to deal with it, okay? So in terms of labial frenum, as we mentioned with the maxillary, we have also labial frenum will be as a labial notch in the denture, but this will be at the lower mandibular denture. The buccal frenum, which create a buccal notch in the denture. So any frenum will be a notch later in the denture. And we should notice the direction of the frenum as well in terms of the movement of the floor of the mouth and the cheek and lips, of course. The lingual frenum, we have the lingual frenum which later on become a lingual notch in the denture, but the most important thing is to notice the attachment of this lingual frenum. Sometimes we have such an attachment just across between the two lower central incisors, and in this term we cannot construct a complete denture unless we have a frenectomy for them to release it. Otherwise, we cannot seat the denture over a movable area, just like that, which lead to dislodging the denture, of course, and we loosening the fitting of the denture. So it depends. Otherwise, maybe some patients do not require surgery, such as surgery, and they may ask for implant prosthesis without removing or in terms of frenectomy. The labial vestibule, providing lateral as with the labial flange of the denture, okay? And of course, it's extend from the labial frenum to the buccal frenum, and we have the buccal vestibule, which is extended from the buccal frenum backward until the area of the retromolar bud. This will create buccal flange of the denture. Alveolar lingual sulcus, or it's called the lingual vestibule. This is the largest vestibule that we have, and represented also by the and affected also by the raising of the floor of the mouth and relating to the lingual frenum as well. It is important to register all the details of such a vestibule in terms of proper designing of complete denture. And of course, the labial sulcus, I would like to mention that the labial sulcus used to assess the vertical dimension, and the buccal shelf provide the support for denture and angulation of occlusal surface of the posterior teeth. The residual alveolar ridge, of course, the primary, sometimes many theories regard it as a primary stress bearing area, while the external oblique is the secondary, the external mylohyoid ridge considered as secondary stress bearing area. So it's many theories about it. However, the alveolar ridge used to assess the buccal lingual position of lower teeth, and it's important for us to recognize this as a ridge fossa in the denture. The retromolar bud, this distal border of the lower denture, it's a point 2/3 the way up to the retromolar bud may be used to approximate the occlusal plane, which that means that this is not included within the occlusal load of the denture. That means the 2/3 in front of this retromolar bud is the last area on which the occlusal table will be occluded, as I mentioned in many slides previously. The location of the saddle of the as the saddle over the horse bag. This is the closal table. Otherwise, the dislodging will be, because this is a movable tissue on this area. And of course, the retromolar bud will create a retromolar fossa in the denture. And this depends on the anatomical landmarks for the patients. Some of them are movable in a bad retromolar bad, movable, very movable, and sometimes a little bit connectivity. That means the connective tissue is a little bit firm. So with each type we should exclude this within the design, or no tooth should be positioned over this area. Now, the external oblique ridge provided an external oblique groove in the denture. This is a bony structure and muscle attachment site that should not be included in the denture bearing area. Now, why this should not exclude? These are a bony structure like a knife, and as I said previously, many theories consider part of it. While generally these should not be included within the denture bearing area, otherwise this will act as a knife for the patient. So sometimes we need to relieve them. And of course the mylohyoid or line, also these are muscle attachment. Any pressure on them lead to cutting the muscle supply, making probably the movement of the mandible impaired. That means the muscles attachment cut it, and so on. Now we have many landmarks, whether included or not. They depend on the type of the residual bone, or the resorption of the bone. Now the mental foramen, these are foramen supplying the most of the anterior part and the posterior part of the teeth. In terms of heavy resorption of the bone, sometimes this foramen, as in the image on the left, become exposed over the ridge, and at any time, whether it is exposed or not, we need to relieve this area and do not produce any pressure on it. And the mandibular tori, these are a bony structure created due to dysfunction in the bony cells, mostly located between the first and second premolar area, and sometimes they are large, so we need to surgical removal, or sometimes they are more than shallow and we need to relieve them. These are not included, of course, in the denture. And the genial tubercle, these are bony structure and a muscles attachment as well. These are within the bone, not exposed, but sometimes we have an enlarging within these genial tubercles, greater and lesser genial tubercles, and this probably may lead to sometimes problems in of course construction the lower complete denture. Now with the incisive papillae, and how can we make use of the incisive papillae? I mentioned previously in terms of aesthetic for the anterior teeth, and of course the lips, and the using the incisal papillae. The incisal papillae is a key landmark in the design of the denture. Why? Because it does not change position as the alveolar resource. That means whatever the child at birth and then until death, the position of incisal papillae is the same. Okay? Now, the incisal papillae highlights the anatomy midline of the alveolar, regardless of the midline of the patient face. Okay? So, what's that mean? We have asymmetrical in terms of size probably, this gives a symmetrical position. Whatever the landmarks or the facial expression is, because otherwise many patients, they have non-symmetrical left and right lips, for example, or ridge, or sometimes with the nose and the profile of the patient. Okay? Now, the labial surface of the maxillary anterior teeth, if we demark the center of the incisal papilla, as in the image at the middle with the rural, and bisecting it, whether we are using many instruments like laser or laser light, or we can use ruler, for example. The position of the maxillary anterior teeth is approximately 8 millimeter anterior to the center of the incisal papilla. So when we deline the center of the incisal papilla, we can just measure 8 millimeter anterior to it. This will be the location of the two central incisor. This measure can be used as a guide for placing the teeth, of course, and this is really, really helpful in terms of we cannot identify the location of the two central incisor, or it's the first step to make the dental technician can get a benefit from the guideline, the landmarks that we have within the edentulous arch. Okay. And the position, while the position of the canine may also be related to the incisal papilla. Now, the incisal tip should be in line with the center of the incisal papilla. Okay? Similarly, the labial surface of the canine are approximately 10 millimeter from the edge of the first rugy fold as an average position. As we notice at the image, for example, on the right side, the upper one is to locate the canine. Okay. Now the labial surface of the canine, if we demark the first rugy area fold demarcation in the configuration, the 10 millimeter from the edge of this first rugy fold, we can identify the location of the canine. And between the canine and the central, we can locate the lateral incisor. As easy as that. I will repeat that, okay? The position of the maxillary anterior teeth is approximately 8 millimeter anterior to the center of the incisal papilla. The canine may also be related to the incisal papilla. The incisal tip should be in line with the center of the incisal papilla. Okay? With the line, that's mean all over the crest of the alveolar ridge. Now, the labial surface of the canine is approximately 10 millimeter from the edge of the first rugy fold. So now we have the incisal papilla and the first fold in the rugy area. They are helpful in setting of anterior teeth. Now, probably a simple device we can use, for example, as Alma gauge, also be used to accurately determine the labial contour of the registration rib. Otherwise, mostly the dental technician may be construct the occlusal rim in term out of the ridge, inside, palatally or lingually. So if you want to identify that the center of the occlusal bite is within the center of the ridge, we can use Alma gauge, and sometimes we can create a laser beam to make sure we can use it. Now the registration is placed on the device, and the distance from the incisal papilla to the labial surface of the registration rim measured. This Alma with the measuring of millimeters, and we can notice that if all the setting of our teeth in terms of trying, and then later on by constructing the denture, they are probably well. Then the device allow the patient's existing denture to be measured and the dimension transferred to a registration room or trial denture. Okay, the quick procedure saves chairside time when adjusting registration rims and copies the position of well-placed teeth from existing dentures. Now, these tools can be really helpful with the aid of the maxillary and mandibular landmarks. Okay. Now we have the alveolar ridge. The alveolar ridge. The alveolar ridge is straight lines are often used between the retromolar bud and the first premolar to represent the center of the alveolar ridge. The image on the left side, we can use a rural to demark with the pencil the mid of the retromolar bud and to the premolar region, and then using the center of the ridge may result in restrict tongue space if severe resorption of the ridge has taken place and the ridge have resorbed lingually. Okay, if resorbed, the image at the middle, the A, showing the resorbed bone. So, what about how we can identify the center of the ridge in this term? Because the resorption going to the lingual part, and this will affect the movement of the tongue, which make it uncomfortable for the patient. This can lead to false tooth positioning and an unstable denture, which may be dislodged by the action of the tongue. Okay. Now, what we are going to do is a better method to first use a pencil or static laser to mark the center of the denture bearing area as at the image on the right side, okay? And at that position, we keep setting the teeth it's an excellent way to ensure the teeth are correctly centered over the most stable part of the denture bearing area. Now, correcting position posterior teeth is also significant in preventing fracture of the denture. When upper or lower posterior teeth are placed too far buccally, the denture become susceptible to fracture because the occlusal force are transmitted down the buccal aspects of the ridge rather than onto the crest of the ridge. And of course, this leads to dislodging with the high pressure on the denture leading to fracture. This causes stress concentration at the midline of the denture, shows a laser used to identify the center of the ridge, and when the wax trying measure, for example, onto the model, it can be seen that the denture teeth have been positioned too far buccally. So using such a laser beam or ALMA to positioning the alveolar ridge and then identifying the position and the crest of the proposed crest of the ridge, and then positioning the teeth make the setting of teeth helpful. Otherwise, as we can notice on the right side image, that the teeth is out of occlusion on the buccal side. Okay, now we have the saddles as well. Now, to achieve stable denture, the occlusal force should be transmitted at 90 degree to the alveolar, and the primary masticatory teeth should be located in the deepest part of the alveolar. This is particularly important for the mandibular rather than the maxillary, because we have mostly the lower first molar is the mostly removed tooth or extracted tooth, so that's why there is a resorption over this area, because it loss of bone supporting the root, and then this produce a resorption over it. Now, The deepest part of the alveolar on the ridge is marked using a pencil and a transcript to the side of the model for use, as we can notice on the left and the middle image. Okay, for use when positioning the lower molar. A profile compass as well used as in the image at the bottom on the left side. This profile compass may also be used to trace the contour of the ridge onto the side of the model to help prevent teeth being seated over sloping parts of ridges. The compass should be kept at right angles to the alveolar when making these tracing lines to indicate the posterior and anterior extent of the most stable part of the ridge. Of course, the part you would put the horse saddle on it are then drawn as shown in the image on the left side, on the right side, and we can notice also the simulating probable movement of the upper and lower in terms of crushing of teeth, and this is the most stable area within the denture. Well, no occluding in terms of also no occluding posterior teeth should be placed distal to the most posterior line, as they would be over this area, over the sloping parts of this ridge, which would cause instability during mastication. The primary masticatory tooth, the first molar, should be placed between the two lines as shown in the image on the right, the bottom one. Okay, never place molar teeth over the distal sloping part of ridge if this means leaving the last molar off the denture. So that's it. It's fine to leave the denture without teeth. Otherwise, this will lead to dislodging the denture. Better functional denture will result by placing the tooth at this position. Okay. Now, a combination of ridge profile and lowest point of the alveolar ridge, a guide for a large molar placement in these images, and this is what the dental technician should looking for and identify before starting working on such setting guidelines. This becomes significant in providing stable for the denture once food is between the teeth. Of course, when a bolus of food is being chewed, balanced occlusion is lost, and the teeth must be designed such that they are unilaterally stable. Okay? And the image at the top on the right side showing correctly positioning molar teeth will allow masticatory pressure exerted during eating to be transferred through the dentures and help to stabilize the denture rather than dislodging it, as would be the case of the molar teeth wherever sloping ridge. Studies show that chewing takes place for approximately 15 minutes per day. It is during this function that we require the unilateral stability. We can rely on retention when dentures are new. But as they lose their food adaptation due to resorption of tissue and bone, so retention is reduced and stability become, of course, important. Now, in terms of retaining the registration information, Uh, when positioning teeth in the registration rim, the information recorded into the rim is lost. The center line and canine lines are easily transferred to the model, but the smile lines and sagittal contour of the incisors are less easy to store, of course. Now, as shown in this images, the details recorded on the labial surface of maxillary registration rim, smile line and labial contour can be recorded using impression body and used to verify correct placement of the teeth. To design the occlusion, there are two forms of posterior teeth relationship for complete denture: the natural and anatomical balance occlusion and the lingualized occlusion, which are going to discuss now. Although these are similar, the lingualized occlusion has a much a much smaller number of contacts between the upper and lower teeth. This allows more control of the pressure directed through the dentures onto the underlying supporting tissue. Okay? The natural anatomical occlusion, the upper teeth are placed in their natural position, slightly buccal to the crest of the ridge. Okay, slightly buccal to the crest of the ridge. Now, typically, these teeth are placed placed starting from the first premolar through to the second molar, creating compensating curve relative to the occlusal plane. Now, the compensating curve is the combination of the curves of Spee and Manson's or Wilson, can be built into the posterior arrangement of the denture teeth. This with the natural anatomical occlusion. So, first of all, placed in their natural position, slightly buccal to the crest, then starting from the first premolar through the second, creating compensating curve. And of course, the compensating curve is the curve combination of curve of Spee and Monson and Wilson, which they are in the natural. Okay, built the posterior arrangement of the teeth in proper way. Now, the occlusal contacts are established. The occlusal contacts are established between the buccal cusp of the lower teeth and the central fossa of the upper, and the palatal cusp of the upper teeth and the central fossa of the lower. Okay? Now, as I mentioned, the occlusal contacts are established between occlusal contacts in natural occlusion. Natural anatomical occlusion is between the buccal cusps of the lower teeth and the central fossae of the upper, and the palatal cusp of the upper teeth and the central fossae of the lower. The teeth also overlap each other in a natural manner, the lower first premolar occluding with the upper canine and first premolar, the lower second premolar occluding with the upper first and second premolars, and the lower molar occluding with the upper second molar and first molar. And we discussed previously the setting of teeth in terms of class 1, class 2, and class 3, and so on. And this is just a review to what we have discussed previously. In natural occlusion dentures, the teeth overlap each other and replicate nature. Okay. Note that the second molar should only be placed if there is room for it. Okay. On the image on the right or on the left side, we can notice, for example, only the first molar. So because we don't have enough space for the second premolar, we have the first premolar, sorry. So we have first premolar because we don't have space for the second premolar. Okay. Therefore, the lower buccal cusp tip translates down the palatal the second molar should only be placed if there is room to do so, okay? Without encroaching to the sloping part of the lower ridge. In this case, if we occlude with the upper first and second molar, that will be fine, okay? A lateral excursion to the right or the left, contact of the working side cusp is maintained. Therefore, the lower buccal cusp tip translates down the palatal facing slope of the upper buccal cusp. Now, the upper palatal cusp remains in contact with the buccal facing slope of the lower lingual cusp. Simultaneously on the balancing side, the upper palatal cusp slide up the lingual facing slope of the lower buccal cusp. In a protrusive excursion, the anterior and posterior contacts are maintained during protrusive excursion, as in the image on the right side, okay, to prevent the denture from tipping. When establishing an occlusal scheme in this way, there are many contacts to consider. This must all be harmonized with the movements of the mandible. The articulator should be programmed to best replicate the mandibular movements in order that the teeth may be engineered to match the patient condyle pathway. This is little room for error, and the teeth are generally designed to have a precise centric position. This means that the intercuspal position contacts established to consign with centric relation are single points to which the patient must close. Okay? That's what we have with the natural anatomical occlusion. Now, with the lingualized occlusion is different than the natural setting of teeth in natural occlusion. It's designed to direct the occlusal force over the center of the alveolar using one contact per tooth. That means the relation tooth-to-tooth relation, not as in the natural one, which is 1 to 2 teeth relation. This simplifies the tooth contacts by eliminating the buccal cusp contact. The resulting occlusal contacts are lingually placed in comparison to the natural occlusion. As we mentioned, the natural occlusion, setting of teeth in natural occlusion, a little bit buccally, while in lingualized they are lingually. Lingualized occlusion teeth have far fewer occlusal contacts than their natural occlusion counterparts. Why? Because sometimes we have semi-anatomical or sometimes monoplane with the mild anatomical landmarks for the occlusal surface. A lingualized occlusion denture teeth are designed with large maxillary palatal cusp that occlude with enlarged opposing foci. During excursion, the single occlusal contacts are harmonized with the movement of the condyle in each direction, creating a pistol and mortar style of occlusion, part to part, okay? The center contacts are wider and longer than that found in the natural teeth, allowing a degree of tolerance when the denture wearer occludes the teeth. Importantly, the single contact per tooth is centered directly over the alveolar ridge to create stability with the lower teeth dictating the lingual buccal position. The upper teeth, having more tolerance due to the border upper ridge, are generally placed buccal to the upper ridge. Now, the occlusal contact occurs between the palatal cusp of the upper teeth and the central fossa of the lower teeth. Tooth-to-tooth relation. The first premolars have this situation reversed. That means that the the central fossa of the upper occluded with the palatal cusp of the the palatal cusp of the lower occluded with the central fossa of the upper. No overlapping of the teeth is introduced, of course. Of the teeth is introduced. The upper tooth only occlude with its honor counterparts. That means first molar to first molar, first premolar to first premolar, second premolar to second premolar, and so on. With no contacts between the buccal cusp of the teeth, the occlusal contacts are lingually placed in comparison to the natural occlusion. This means that the forces are directed over the lower ridge, resulting in the most favorable situation for mechanical stability. This form of occlusion is indicating where the alveolar ridge is less pronounced and stability of the denture is paramount. It should be remembered that although centric relation and the movements of the mandible may be recorded precisely, these positions and movements are subject to change throughout the day or over time. The difference in centric relation over a 24 hours period has been demonstrated, and change over time may result from a number of causes, including relaxing of the muscles if they have been working from a poor position previously, remodeling of the condylar head, or reduction of inflammation. Whatever the reason, it may be considered that the best long-term treatment is to provide an occlusal scheme that will allow the patient to adjust and move freely while still maintaining a stable denture. With the one cusp into a fossa arrangement of the teeth, with this method, it is possible to create a long and wide centric situation to allow patients a freedom in centric. Similarly, those who have problems achieving the same occlusal position habitually will be able to maintain balanced occlusion. During the final grinding in of the teeth, a balanced occlusion can be achieved even if the patient makes a protrusive or extrusive shift of 2 to 3 millimeters. Now we are already discussed the occlusion and the positioning of teeth, and in terms of occlusal natural occlusion and lingualized occlusion, and the quiz for the next week to be prepared enumerate the maxillary and mandibular anatomical landmarks that aids to position denture teeth. Thank you for today, and take care for next week. See you.